logged in, and we are expecting a lot more. Uh, the New Kolkata Academy of Pediatricians, as you're aware, had started this series known as the Pediatric Parliament Series, wherein we have put up contentious issues for eminent people to debate on, and at the end of the day, give a consensus statement so that, practicing pediatricians or neonatologists, they can follow them. The purpose is to have a very, very healthy debate, and it's only in the best interest of academics that we get the best practitioners of the skill and the art of neonatology today, and let them impart whatever is their knowledge and their experience to us who are willing to learn. Uh, as they say, breathing is one of the greatest pleasures of life, and yet we neonatologists are often faced with this challenge of getting a child to breathe. So, having said that, I would now hand over to Dr. Bikramjit Das, who is the consultant neonatologist and in charge of the tertiary neonatal unit at Bhagirathi Neotia Women and Child Care Unit at Newtown in Rajarhat. So over to you, Bikramjit, and you would be the one moderating today's session. All the very best to the panelists.
Thank you, sir. Thanks a lot. So I welcome all the guests who have taken time on this evening to attend this session. But I do promise you that it's going to be a very fruitful session. The two of our panelists, they're very well dignified and very scientifically oriented, and we have a good topic for them also. So I'll just share my screen. Is my scene visible?
Very much. Go ahead.
And I'm audible also.
Yes, yes.
So the two panelists for today's topic are Dr. Binesh Balchandran, who is a consultant neonatologist at Malabar Institute of Medical Sciences, Kerala, and Dr. Abhishek S. Aradhya, who is a consultant neonatologist at Ovam Hospitals, Bangalore. The topic which we have decided for today is the use of bovine versus porcine surfactant for neonatal respiratory distress syndrome. And this is something which covers most of the neonatologists. Every neonatologist or pediatrician who is dealing with a newborn has to use this quite often. So before we move ahead with the presentations, I'll share some few slides. So these are the disclaimer slides. The discussion will be restricted to animal-derived surfactant and not synthetic surfactant. The discussion is based on scientific evidence between the two types of surfactant, that is bovine and porcine. There is no intention to promote or develop bias towards any particular type, and the choice of surfactant will solely reside with the attendant of this meeting after hearing all the relevant evidence. The objectives for today's presentation would be, we'll be understanding the types of surfactant, we'll be having a knowledge of the clinical trials involving the two surfactants, and then we will have a discussion on evidence among the two types on various clinical and non-clinical parameters. The flow of this presentation would be such that I shall introduce the topic, give you a few slides, and then I'll be raising one clinical question or non-clinical question at a time, on which first Dr. Abhishek, who will be defending the porcine surfactant, will give his view, and thereafter Dr. Binesh, who will be defending the bovine surfactant, will be giving his views, and once their views are in, then we will be taking the house questions on that particular clinical question and then move ahead, and towards the end both of them will be giving their conclusion statement. Then I shall summarize, and then we can have the further questions as and when present. So moving ahead, respiratory distress syndrome, we are well aware that it's a gestation-based thing, and at lower gestations, the incidence is much higher than at higher gestations. Amongst the other things which are used in the treatment of respiratory distress syndrome, surfactant is one of the major things, and this is the basic differentiation or the basic composition of the surfactant, which we can see of unsaturated phosphatidylcholine, the DPPC or diphosphatidylcholine, proteins, and several other components. Now let us understand this slide, because henceforth this will be important. Now, as I stated, we shall be only focusing on the natural surfactants. So that comes into two forms. One is the minced lung extracts, and one is the lung lavage extracts. The minced lung extracts consists of three types. One is Beractant. Survanta is the brand name for that. One is Poractant alpha, Curosurf. One is Surfactant TA, Surfactant. And the lung lavage extracts consists of the bovine lipid extract surfactant, or BLESS, which is the neosurf or liposurf, calfactant, which is infrasurf, SFRI1 or alveofact. We shall be mainly focusing on these three brands or these three types because they are the ones which are usually available in our region. So one of them is Survanta, which is the bovine surfactant of the minced lung extract. One is Curosurf, Poractant alpha, and one is Neosurf or the BLESS. The doses which are recommended by the companies are as such. We would standardize them into the milligram per kg of phospholipids. That would be easier. But coming into the ml per kg, that would be a bit different. So for Survanta, 100 milligram per kg is equal to 4 ml per kg. For Curosurf, 200 milligram per kg is equals to 2.5 ml per kg. For Neosurf, 135 milligram per kg would be 5 ml per kg. The available formulations of these are Survanta comes in 4 and 8 ml vials, Curosurf in 1.5 and 3 ml vials, Neosurf in 3 ml and 5 ml vials. These are the costs of these vials accordingly, but I must say that it might vary from state to state and hospital to hospital depending on several other factors. These are the basic differences between the bovine type and the porcine type. So let us focus more on the bovine type, Survanta, Neosurf, and alveofact, and on the porcine side on the Curosurf. So you can see some differences are there in their protein compositions as in the protein compositions. This is a crowded slide. I'll just take you through it. These are basically the studies which have enrolled, the randomized trials which have studied on these surfactants, porcine versus bovine. You can see the number of sample sizes, the average gestation, average weight, the intervention. The intervention, you will see most of these studies have looked at Curosurf or Poractant alpha porcine 200 milligram per kg for the first dose versus 100 milligram per kg of the bovine type. And if repeated doses of porcine are required, they have used 100 milligram per kg of porcine. They have looked at various short-term goals primarily, and the meta-analysis which the panelists will be speaking on have looked at their long-term important clinical outcomes also. The important studies you can see amongst these are the study number 2, Musavi, 3, Najafan, 5. So these are important in the sense that they have large number of study subjects. So they will have a larger weightage in the meta-analysis. Okay, so now let us go to the first clinical question. Effects on BPD and or mortality. So I'll first ask the porcine defendant, Dr. Abhishek, to take up the mic.
Thank you, Bikram sir, for giving me the opportunity to speak with most of these people. Or so first, if you look at the effect of BPD, so the poractant versus bovine surfactant, I think most of the attendants must be aware that this is a forest plot which summarizes the evidence of randomized controlled trials. So for people who are not aware, so previous slide, people who are not aware of this forest plot, so previous slide, please. Yeah, people who are not aware of this forest plot, so this forest plot actually has certain important aspects. So you can see a single black line as well as a dotted red line. So the black line actually indicates line of no effect. On the left hand side of this line of no effect lies the results of towards the intervention, that is the porcine surfactant. On the right side is the bovine surfactant. Individual studies are represented by small lines passing through the square boxes. The size of the square boxes indicates weightage given by each study, and the two lines indicates the ends of the lines indicates the confidence interval. So if the ends of this confidence interval lies within the intervention, that means the study is significant. So overall, the study is summarized with the help of a diamond tip, that is, the diamond ends actually run through a dotted line, which actually indicates the odds ratio of these studies. The lateral ends of this diamond actually indicates the confidence interval. So from this forest plot of 12 trials involving 1194 neonates, it is clear that porcine surfactant at 200 milligram per kg versus bovine, the odds ratio is 0.68. That is meaning there is 32% reduction in bronchopulmonary dysplasia by using poractant. Next slide, sir. I think once we have learned the forest plot, I think if you look at the effect on mortality with the porcine surfactant, with similar number of trials and similar participants, you can see that the tip of the diamond is touching the line of no effect. So that is the confidence interval, the lateral end is touching 1.15, although the odds ratio is 0.7. So although the trend is towards, benefit is towards poractant, the tip is touching the line of no effect. So statistically speaking, there is no difference in mortality between both the type of surfactants. Next slide, sir. So if you look at the composite outcome, that is either of BPD or mortality, poractant versus bovine surfactant, the odds ratio is 0.63, meaning there is 37% reduction in composite outcome if you use porcine surfactant at 200 milligram per kilogram. So instead of the odds ratio, here we have used a statistical figure called number needed to treat. The number needed to treat says that how many number of patients will get benefited by using this particular drug. Here number needed to treat for porcine surfactant is just 11, meaning compared to bovine surfactant, one patient of porcine surfactant we can prevent with BPD or mortality if 11 patients are given bovine surfactant. So this number needed to treat 11 actually is better than antenatal steroids. That is the effect of porcine surfactant compared to bovine surfactant is what I would like to end my talk here for this debate. Next slide, sir, to summarize. So you must be wondering, we are comparing here 200 milligram per kg of porcine versus 100 milligram per kg of bovine. So you must be wondering that there are two different sized apples. So unfortunately, most of the evidence, whatever in the trials we have seen in meta-analysis is that 12 trials out of 14 trials available have compared 200 milligram per kg of porcine versus 100 milligram per kg of bovine. There are only two trials which have direct comparison of 100 milligram per kg of porcine versus 100 milligram per kg of bovine. Evidence-wise, we just have around 176 extra babies. Let's look at comparison of just 100 milligram per kg of porcine versus 100 milligram per kg of bovine. So next slide. If you look at any dose of poractant, the evidence says with these randomized controlled trials or meta-analysis is that with 14 trials, still we can have 29% reduction in BPD with any dose. Next slide. So with composite outcome of BPD or mortality, again, this forest plot, you can see the diamond is towards the left-hand side. There is the odds ratio is 0.66, that is 34% reduction in composite outcome. So if you compare any dose as well, still the porcine is significant. Next slide, sir. So this is about the direct evidence. If you look at the indirect evidence for BPD, I think this study is from the Jensen et al. Neo Reviews review study, which looked at preventive strategies for BPD. So it's a busy slide, I understand. So the first part actually deals with respiratory support strategies, while the second part actually deals with surfactant administration. If you look at the surfactant administration, I would like to gain your attention towards the last row, that is LISA versus INSURE. If you look at the number needed to treat to benefit, you can see number needed to treat benefit is just 12 for LISA if you compare INSURE. You must be wondering, I have taken the discussion from surfactant preparation to LISA. So let's look at why did I bring this discussion. Next slide. So this is because I wanted to gain your attention on Bayesian network of meta-analysis, that is for BPD prevention, we have ranking of strategies for the strategy to deliver respiratory support. So we are all aware with the landmark Isayama Bayesian network meta-analysis that LISA ranks 1 in prevention of BPD. So why we are discussing LISA? Because 4 out of 7 randomized controlled trials on LISA have used porcine surfactant. Next slide, sir. So porcine surfactant at 200 milligram per kg is known to reduce BPD by 32% and composite outcome of BPD and mortality by 37%. A very few 100 milligram per kg or direct comparison of 100 milligram per kg of porcine versus bovine trials. And in LISA, if you see, majority of trials have used porcine. This is because it is advantageous to use porcine because of lower volume, hence easier delivery and thus reduction in BPD. So I would say porcine is advantageous in reducing BPD at 200 milligram per kg, as well as it is beneficial if you are using LISA as well.
Thank you, Abhishek. So prima facie, it looks that a good meta-analysis is favoring porcine surfactant, but let's see what Dr. Binesh has to say, because I know he is an excellent speaker on counteracting things. So Dr. Binesh, now the slide would be yours. Dr. Binesh, you are muted.
Sorry about that. So again, first of all, let me thank the organization, especially Dr. Bikram, for giving the opportunity to speak in front of such an esteemed audience. So next slide. So before going to the evidence per se, let me start with a fun fact. Hopefully you all know these two gentlemen. This is Dr. Todd Kerstead and Dr. Ben Robertson. And you should have rightly guessed, these are the people who invented the porcine surfactant, that is a Curosurf. And the name Curosurf is a short form for Kerstead Robertson surfactant. Next slide. And if any of you are interested, I recommend this article for all of you to go through at least once. A unique story in neonatal research, development of porcine surfactant, written by Kerstead himself. A very inspiring writing, how they discovered the utility of pig lung, how they extracted the surfactant, how they tried and how they succeeded, and how they marketed this. A truly inspiring article to read. Next. That being said, when Bikram asked me to debate on the use of surfactant, I did somewhat a bit of homework on this to know what is the general practice. So I called upon around 48 units, and mainly in Kerala and a few units outside of Kerala. And interested to know that only 4 out of these 48 units uses Curosurf. And even on those 4 units who uses Curosurf, 3 units uses it a dose of 100 mg per kg per dose, mind you, which is not the recommended dose to start with. 200 mg is the recommended dose to start with. 42 units use Survenda with or without Neosurf, and 2 units use exclusive Neosurf. I'm not saying that this is I'm not saying that this is the general pattern all over the India, but generally most of the units in India uses Survenda. The reason being the cost, the supply efficiency, etc., etc. Next. Again, already it's been said that the low volume for Curosurf is advantageous. But mind you, that is a very personal perception. There is nothing clinically to suggest that low volume has some advantages. The LISA studies used mainly porcine because those units who are exclusively using porcine are simultaneously the one who discovered or promoted LISA to begin with. That's why the 4 out of 7 RCTs are with porcine. But mind you, the other RCTs are with Cerventa. And I know personally a lot of units in India who uses LISA and abroad also, who are very comfortable with Cerventa even. And especially if you look at other innovative strategies of delivering surfactant, like nebulizer surfactant, there is a clear-cut advantage for high volume in such measures. If you see the nebulizer surfactant trials, almost all are done with Cerventa or bovine surfactant. And not only there is any clinical evidence to say that the low volume is advantage, but in counteractively, there is some clinical evidence to say that a low liquid dose may be a limiting factor because it limits the distribution to the lung surfactant, especially if you use it at 1.25 ml per kg. It actually reduces the overall amount of active ingredient delivered to deep lung so that the distribution will be very unequal and it may not reach the periphery of the lung. And mind you, this is one of the reasons has been suggested why a dose of 1.25 ml versus 2.5 ml of porcine surfactant is much inferior to 2.5 ml. It is not only the dose, the volume also decreases so that the equal distribution chance decreases and there is a chance that it may not get distributed equally or to the periphery. Next. So the volume advantage practically is a personal perception as for me. And before I go to the meta-analysis per se, whenever you interpret or read or a study, there are few points we should all ponder. One is that the conclusion of study should be either accepting or rejecting a null hypothesis. So you formulate a null hypothesis, you do a study or you synthesize a meta-analysis, and if the p-value is significant, you reject the null hypothesis, otherwise you accept the null hypothesis. In ideal circumstances, there is nothing called a partial acceptance or partial rejection of null hypothesis. So that whenever you hear terms like trends favoring this and this, these are often meaningless and just show-offs. And whenever you see 2-3 outcomes are combined, like BPD plus mortality plus neurodevelopmental outcome, these are primarily made to decrease the sample size in individual studies, to decrease the need of sample size, high sample size in individual studies, and in meta-analysis to create a statistical significance. So most of the time that is a problem with the trends and combined outcomes that are not very much meaningful. And the next important point is the generalizability. So whenever you read a study, we should be very, we should scrutinize that what is the patient population? Is it the same patient population that I am seeing and or I am treating? And is the facilities that they use in the studies, is it available to us or am I using the same facilities? And what is the drug used? Am I using the same drug? And what's the dose they use? Am I using the same dose? And what's the time period? And this time period is very important, especially in anything that is related to neonatal respiratory care. Because over the past 1 or 1.5 decades, the neonatal respiratory care has advanced so much and so that any study which is done 15 years back is almost like an absolute one nowadays. Because the strategies of BPD prevention, early use of CPAP, your LISA, etc., a lot of things has been changed. So again, the RCTs are a good thing. These are one of the best quality evidence that you can, but they should not be the only ones that matter, because you should be also aware about the real world evidence that is going on this time period of age. Because what the problem with RCT is that in RCT, you control all other cofactors other than that you are studying, and it should be a very controlled environment, and you cannot expect the same result when you use it in clinical practice in many other settings. And meta-analysis is something that we get as close to truth in scientific literature and the medical literature. But mind you, even meta-analysis are prone to statistical errors and bias, especially in selection of the studies. And the pragmatic study is something done to increase the generalizability. But if you are too pragmatic about the inclusion criteria, then it poses its own problems with generalizability. So next slide. So you could have already guessed all these points I brought out is just to point out a few faults with the meta-analysis that already been presented. The Poisson versus Bowen surfactant therapy, the Trident et al. Meta-analysis. If you read this meta-analysis, you will not feel like using a Bowen surfactant in any of your clinical practice because almost all the outcome is clearly in favor of Bowen surfactant. But mind you, in this study, they compared Poisson surfactant with all other Bowen surfactant combined, not one Bowen surfactant, irrespective of the answer. And that the reason they gave for that is that in the previous meta-analysis done by Cochrane in 2015, the Bowen surfactant has been already deemed to be clinically equivalent. And that is a very dangerous assumption to make. The Cochrane analysis has only 3 or 4 studies comparing the Bowen surfactants, and the sample size were only 200 or 300 something. So just that one meta-analysis, including 3 or 4 studies, failed to differentiate between 2 or 3 products of Bowen surfactant. You cannot assume that these are clinically equivalent. That's the first point. And they did not perform an analysis of 100 mg per kg versus Bowen surfactant. They did analysis versus any dose, that is 200 plus 300 of Poisson versus Bowen, not exactly 100 mg per kg Poisson versus Bowen. Unfortunately, this is the dose that many in India, the practitioners uses for Curosur. Next. Again, I already sent my concern regarding using the trends. Next. The constraint already been described a bit. So, not only that the Bowen surfactant differ in its constituents, there are even clinical evidence to say that comparing the studies, these are not clinically equivalent. Different studies are given different results favoring Beractin versus Calfactant or Aliofact, etc. Next. So what we really need is a meta-analysis comparing Curosur versus either Surventa or Neosurf or both. Because these are the only 3 surfactants that we use in India. Even if you see a meta-analysis saying that Curosur is 100 times better than Aliofact or Calfactant, I'm not concerned because we are not using Aliofact here. We in India uses only Surventa or Neosurf or Curosur. So I'll be only interested in an analysis which comparing Curosur versus Surventa with or without Neosurf. And again, I'll be interested to see a study which compare 100 mg per kg specifically alone of Poisson versus Surventa. Next. Luckily for us, there is one study when newer meta-analysis exactly on this aspect done none other than Manuel Sanchez Luna came in 2020 in Journal of Perinatology. They compared Beractin, that's a Surventa versus Poisson or your Curosur. That is a systematic review of real-world evidence and also RCTs. Next. So we come to the question of mortality and BPD. Next. This already been presented by Abhishek, and he made my job simple about explaining the forest spot. And I already said about the combined outcome of BPD and mortality. That the mortality alone was not significant. So whenever you have an outcome that is on borderline significant and an outcome which is clearly in favor of Poisson, if you combine both, you are bound to get a significant outcome. That is not much of meaning. Next. So coming to the Dr. Luna et al. Meta-analysis, if you compare Poisson, any dose of Poisson, 100 or 200 versus Surventa, regarding the mortality, you can see that the triangle touches the line of non-significant. So there is no significant effect either in favor or in rejection of Curosur. Next. The same with 200 mg per kg per dose, no significant effect of mortality alone if you compare with Poisson and Surventa. Next. They did an analysis comparing only 100 mg studies using only 100 mg per kg per dose of Curosur versus Surventa. Again, no significant effect on mortality. Next. Coming to BPD, you saw that the previous meta-analysis showed a clear-cut advantage of Curosurf for BPD, but mind you, there were studies who used alveofact and calfactant in it. If you remove all those studies and just take the study which use Bractant, that is Servanda, that is available to us, again, if you compare with the Bractant prolactin alpha, no significant effect on BPD. Next. If you use a specially take a dose of 200 mg per kg per dose of Curosurf versus Bractant, again no significant effect. You can see that there is something it's called a trend or to it, but that touches the line of disability, the line of non-significant. And if you use those studies only which use 100 mg per kg per dose, you can see that damage is absolutely on the line of not significant, and even some of studies favor that of Bractant in fact. Next. And the problem with BPD is that various authors define BPD in different ways. So that's why whenever you take BPD as endpoint, there is a difference in meta-analysis. So if you take BPD as a definition as oxygen requirement 28 days only, again, there is no difference between those endpoints and studies. Next. And if you take the BPD defined at 36 week of post-conceptual age, again, no difference between Curosurf and Bractant or Servanda. Next. And I mentioned you about the real world data. Real world data means these are non-randomized studies, but most are otherwise prospective studies, which are done in over the last 5 to 7 years. And you can see that none of this, even the meta-analysis of this real-world evidence, there is no significant effect on either death or BPD, combined BPD or death or BPD, where in Bractant versus prolactin alpha. In fact, many of the studies, in fact, favor Bractant, but that doesn't that doesn't make it significant in statistically. And you can see the sample size in these. These studies are combined sample size of more than 50,000 patients, and these are done in over the last 5 to 7 years. So if you ask me personally, I would go with a study sample size of 50,000, even if it is non-randomized and which is done over the last 5 to 7 years, than an RCT, which was done 15 years back in 2000 or 1995 with a sample size of 100 to 125. Next. And there are still recent things like the coil study published in 2020. I took this study simply because this is one from developing world in South Africa, which is very much comparable to in our Indian data. Again, no difference in BP, death, hemorrhage, or second dose. And there are 1 or 2 studies which compared real-world evidence data, which compared 100 mg per kg specific for porcine versus Bractant. And in those group, almost all the studies favored Bractant, in fact. Next. So I guess that's with the BPD and death. Obviously, if you consider if you pour all the bovine surfactant, there's some evidence to say that Curosurf does better. But if you remove calfactant and alveofact, and if you just take the Servanda, that is most common thing that is used in India, and that's available to us, there's absolutely no difference to say that, nothing concrete to say that either 200 or 100 mg per dose of Curosurf works better. And with 100 mg per kg, most of the studies are even in favor of Bractant. Back to you, Vikram.
Thank you, Dr. Binesh. So very good points raised. Now I'll just try to bring in one important point which Dr. Binesh has very rightly highlighted. Now the problem with a less common outcome. Now, if you have a less common outcome, and if you want to if you want to look at that outcome in a single study, you will have to take a large number of sample size. To avoid that, you do a meta-analysis. Now, if your studies are not similar, then your outcome will not come as truth. And the biggest problem in these surfactant studies are 2. One is they have been spanned over 20 years. So in these 20 years, after, as Dr. Binesh said, the non-surfactant treatment of BPD has changed a lot. So if you can see, I'll just take you back to the few slides which we were seeing. So here you will see, as Dr. Abhishek also mentioned, you will see that the newer studies are towards more favoring poractant, while the older studies had a wide confidence interval. This is something which was seen in both of these studies. So my question to both of your panelists would be that do you feel that over the period of time it seems that the studies are favoring poractant, the recent ones, as compared to the previous ones, and if we leave aside the studies which are before 2010, still it seems poractant seems to be beneficial. I do understand the real world data has to be taken into account, but my question to Dr. Binesh would be that what do you expect the 200 versus 100 to behave if we do the studies, if we keep on doing the studies? Yeah.
You just brought out the point. I actually thought the same, and in fact, I charged my statistician with the same task of doing a mini analysis of these studies, removing all the studies who were done more than before 2010. But the problem is that you will be left with only one or two studies, because even though the studies done published in 2012 and 2013, they have been done before 2010. So if you took the cases studies published after 2010, even then, if you analyze, there's not there is, if you must, you can say that there is a trend towards so and so, but the confidence interval is too large to say that there is a definite trend towards anything. So we don't have that much data to do any analysis after 2010.
So my question to Abhishek would be now that, so Abhishek, what kind of trial, if suppose you were wanting to do, and I expect it would be a multicentric trial definitely. So what kind of trial you would like to design considering your intervention? I would be interested in also taking Lisa into account. I believe you would also take that into account.
Probably if we standardize the method of surfactant administration, like only Lisa studies, and use porcine surfactant at probably 200 milligram per kg, or you have two groups, 200 milligram per kg one group and 100 milligram per kg porcine one group, and compare just with probably most commonly used bovine surfactant, possibly Servanta is what the previous study mentioned. We can look at outcome of just BPD here.
I think a four intervention trial of Lisa, Ensure 200 milligram, 100 milligram would be a feasible thing. What do you say, Dr. Binesh?
The problem is that the recommended dose of Curosur is only 200. So it is practically unethical to do a trial with 100 mg per kg. So I don't think, I greatly doubt the practicality of such a trial.
But it would be a nice study to do. Okay, so we'll move on to the next question now. So effect on the need for redosing. So Dr. Abhishek would defend the porcine part first.
Actually, redosing is a very complicated issue to handle, because redosing depends on multiple factors, like what is the amount of antenatal steroids given, what's the timing of surfactant delivery. And most of the studies actually would not have used redosing as a primary outcome. That would be a secondary outcome. But with the available evidence, if you see with the meta-analysis of Trident et al., with same 12 trials comparing 200 milligram per kg versus 100 milligram per kg bovine surfactant, you can see the diamond is clearly on the left-hand side. So with the odds ratio of just 0.31, that is, we could say that there is 69% reduction in redosing and number needed to treat is as low as 4, which is lower than, I can say, even therapeutic hypothermia for birth asphyxia. That is, if you use in 4 units bovine surfactant, just one unit if you use poractin, you can prevent redosing. So that is the great number of just 4 you have number needed to treat with poractin. That's an excellent number, I would say. That porcine surfactant is excellent in preventing redosing at that dose.
Okay, so Abhishek has excellent NMTs in his hand. So very difficult to beat them. Yeah. Okay, Dr. Vinish.
Okay, next slide, please. Next slide. Again, redosing is the requirement of redose or success rate of single dose, I may say. That is a very complex issue to handle. Again, the trident meta-analysis, if you see, is clearly in favor of the curosol. But mind you, just look at the individual studies. Those who are in the forest on the left side, the most significant, those studies who showed the highest success rate of curosol with a single dose. The Garenbagi 2014 study, the Malloy study, the third one, the Mulavi study. If you just see those things, you can see that in one study, in the control arm is bovine surfactant. They required next slide, please. Next slide, please.
Yeah, just.
Okay, just see these 3 studies. The Garenbagi study 2014, they required 70% of the patients in bovine surfactant required second dose. Again, the Malloy study, 70% of the patients required second dose. And I'm sure that anybody who used bovine surfactant, at least in 10%, will disagree with this. This is not what we see in real life. We don't see second dose requirement of 60, 70 or 80% anywhere when we use in real life. So why it is happened? You can clearly see that all these studies which is clearly in favor of poractin are not applicable to us, because the Garenbagi study, they use alveofact, which is anyway we are not concerned about. The Malloy study, even though it was done in 2005, you are very interested to say that they use prophylactic surfactant, which nobody nowadays use, and they never use CPAP. They just intubated and gave and keep the baby intubated and give second dose whenever the oxygen becomes. So these practices are not done nowadays. So these things, these studies we can straight away remove. Even the Musavi study, they use alveofact. So you cannot there's no meaning in interpreting the results of these studies. Next slide. So I just went to the website of curosol. The curosol generally strongly advertise that there is a high success rate on single dose. And these are the studies they quoted in their favor in their website. The DISDA study, Santry, Dani, Ramanathan study, and Verde study. These 5 studies. Next. So you can see that the success rate of single dose is something up to 75 to 90%. Next. But mind you, these are the only 2 of these studies compared poractin versus baractin. The other 3 were just examining alternate methodologies for dosing of poractin alpha. All of these studies were complex RCTs, but they were a very small and extremely select group of population whose supervision management may be very different from patients that we are recruiting on other clinical trials. Just give you an example. In 4 of these studies, the recruitment rate was 0.3 to 1 patient per site per month. That means that they practically, there are centers even they recruited only 1 patient per 3 months, over 3-month period. So that was the scrutiny of the that was level of scrutiny that went into selection of the patient, and that was the level of, you can imagine the level of monitoring that has been gone. So obviously, that type of monitoring or scrutiny cannot happen in real life, especially with us. Next. And there are various other studies which has tried definitely look at the redosing data. And you can see that the JEDAS, there was no difference between the redosing incidence between calfactant and the protein alpha. Mind you, that is calfactin, not baractin. And the G1 study, they gave that the single dose, they consistently over the protein alpha, calfactin, baractin. All the three have a constant high rate of success with single dose in the range of 77 to 83. And interestingly, the baractin, in fact, the success rate were higher. And mind you, these are the numbers that generally we see in the real life. Whenever we use surfactant, whether it is baractin, calfactin, protein alpha, most of the time we get a success rate of 75 to 80%. That is a real world evidence that I guess almost all of us agree. So my point is that the rate of single dosing or the success, or in other way, the success rate of single dosing appears to be dependent on the site and your practices and not on the surfactant per se. So that's a very complex issue and very variable issue. So not much pointing, dumping on any meta-analysis and over the previous studies. So that's my take on the redosing issue.
Okay, thank you, Dr. Binesh. So just before moving ahead, we'll just take a break and look at the chat box. So we have a few questions. So I think this 100 milligram per kg is not officially recommended by Curosurf, that I can see. Prophylactic versus treatment dose for surfactant, I think that is a different issue, slightly away from this discussion. But as of now, prophylactic is restricted to, I believe, less than 26 weeks and 26 to 28 with who have not received antenatal steroids. Other than that, it is CPAP plus minus oxygen requirement based. I think this point, Dr. Abhishek, if you can take it, I think Dr. Shamik is asking, explain redosing. So I would think they would be wanting to know what criteria do you use for redosing? I think that would be important.
So generally, if you look at redosing, redosing comes after the first dose is given. So with the available current recommendation, generally we prefer delivery room CPAP. After delivery room CPAP, we generally prefer early selective surfactant usage. Early selective meaning early is we prefer to give surfactant as early as within 2 hours, and selective. So in the current evidence, I think prophylactic surfactant, I think people who are managing beyond 26 weeks, there's no question of prophylactic surfactant, as Dr. Bikramjeet sir mentioned. So it is only the selective surfactant. We select neonates who have moderate to severe respiratory distress syndrome. With the era of at least 50% antenatal steroid usage, if you have a neonate with moderate to severe RDS, that is requirement of FiO2 of at least more than 30% on a PEEP of 6. PEEP of 6, this number comes from the European consensus recommendations and well supported by the recent Canadian Pediatric Society recommendations, which gives a cutoff of at least beyond 30 to 50% for surfactant usage. That is, if a neonate is requiring PEEP of 6, FiO2 beyond 30%, you give surfactant as early as within 2 hours. So if the neonate continues to have distress despite giving the first dose, then probably you consider giving the second dose. The second dose, the timing actually varies depending upon various surfactant preparations based on the manufacturer recommendations. So for the redosing, although we do not have any exact timing recommendation from the European guidelines, the previous, I think the February 2021 Canadian guidelines mentioned that after 6 hours after the first dose, if the neonate continues to have features of moderate to severe RDS, meaning the FiO2 requirement is still beyond 30%, you can consider giving the second dose, that is redosing. For the redosing, for the porcine surfactant, the recommendation is to use a lower dose, that is 100 milligram per kg. For the bovine, you continue to use the same dose of 100 milligram per kg. Generally, we use 2 doses. Rarely, we may require 3 doses. I think that should answer the question of redosing.
Yeah. Another question is, can we interchange the type of surfactant while redosing, considering the cost? So that I think is more of a non-evidence based, but yes, it needs to be done considering the real world scenario. And so the effect you cannot ask regarding those things. Yeah. Dr. Binish, yeah.
I would like to comment on that.
Yeah, please.
But probably maybe in the postoperative rate, because my comment on that, that if you can't afford a second dose of Curosur, don't use Curosur for any patient.
Yeah, definitely. Because the second dose is important. So, okay, so we move ahead. So the next question is effect on air leaks and pulmonary hemorrhage. So Dr. Abhishek for the porcine.
I think if you look at air leaks, again, this is not a primary outcome in most of the studies. With the available evidence from these trials, if you look at the forest plot from the Trident et al. Meta-analysis, you can see the diamond is clearly on the left-hand side. The odds ratio is 0.5 with the confidence interval well within the line of no effect. So with this study, we can conclude that there is 50% reduction in air leaks if you are using porcine compared to bovine, and the number needed to treat or number needed to harm by using bovine surfactant is 21. That is, if you use one porcine, so you can prevent air leak compared to 21 neonates if you're using bovine. So porcine surfactant stands well ahead compared to bovine surfactant with number needed to treat. It's better than using CPAP for RDS, I can say, for air leaks. For pulmonary hemorrhage, so with the available evidence, again, I would say porcine is not better than bovine. So for pulmonary hemorrhage, I would say both are similar with the available evidence from 10 trials.
Dr. Vinesh.
Next slide, please. Again, for the obvious reason that I already mentioned in the introduction, I would disregard the Trident analysis as far as possible, because that is not much very much reliable to us. The other meta-analysis, that is Luna et al. Meta-analysis, which compared between Curosur versus Survenda, you can clearly see that considering pneumothorax and air leak syndrome, there is absolutely no difference between the two surfactants. Next. Even if you use 200 mg per kg dose, no difference between pneumothorax and ALS. Next. If you compare with only study with 100 mg per kg per dose, again, no difference between Curosur and Survenda, comparing Curosur and Survenda. Next. Again, the real world data clearly shows no difference between air leak syndromes when you compare between Curosur and Survenda. Next. Now, the problem with the lung hemorrhage is that the Luna et al. Meta-analysis didn't look lung hemorrhage, pulmonary hemorrhage as one of the outcomes. So, I am left with the Trident meta-analysis. Again, if you compare with 200 mg per kg per dose of Curosur versus bovine surfactant, again, there was no significant difference between the two studies that Abhishek already has showed you. Next. But the same authors then it also use another analysis that they use Coractant alpha at any dose. They include studies which use 100 mg and 200 mg and combined them. And when they compared with the bovine surfactant, surprisingly, you got a very significant effect, significant outcome that is clearly in favor of Curosur. So that is very odd to see, because the means that the 100 mg per kg for Curosur is working better than 200 mg per kg, because you get so much clearly air. But mind you, just look at the study that the Ramanathan et al., which is circled in the red. You can see that this study alone is the one which is pulling the whole combined effect of the meta-analysis towards the favoring side of the Coractant alpha. And just see the event rate in the control arm. The event rate in the control arm, that's a bovine surfactant. It stated that they had 67 cases of pneumothoraxes out of 98 patients who received bovine surfactant. Now, anyone who have ever entered a NICU and seen at least 10 patients with RDS will disagree with the fact. Unless otherwise you give surfactant through a thoracotomy tube, you cannot produce such high incidence of pneumothorax anywhere. So, next slide. I went back to the study. Mind you, the quoted the study as Ramanathan in 2014. There is no study like that. It is actually another study done in 2014, published in 2004, which is they wrongly labeled 2014. And even in that study, just look at, they compared with the prolactin alpha 100 mg per kg versus prolactin alpha 200 mg per kg versus Peractin 100 mg per kg. And you just see there are only 5 incidents of pneumothoraces out of 98 patients who received Peractin. And if you compare, in fact, the incidence were least in Peractin. So this 5 out of 98, next slide, somehow misrepresented as a 67 out of 98 in a meta-analysis, which forced them to give a false or misleading interpretation of very low rate of lung hemorrhage with the prolactin alpha. And they even included that in their conclusion. So this is a grave error, something like a schoolboy error. This is not at all expected from such a esteemed authors of Pradang and Dang. So that just that I have to also say with this meta-analysis, because this such of careless data entry for other thing, then we are bound to check all the incidence rate in all the studies, which is practically very difficult. But mind you, I did check all the incidents in all studies, and there was some more mismatches, but not this grave event. Next. And even the other 2 studies which showed very significant effect in this meta-analysis in favoring Peractin, the Musavi one, they use alveolar fact, and most of the pneumothorax were in alveolar fact group, not in Cerventa group. Again, the incidence of pneumothorax was least in Cerventa group. The other study was Carrera. They had a pulmonary hemorrhage incidence of 26%, but mind you, that's a very small number of patients, only 46 number in combined with 201. So nothing can be said of that study. Next slide. Again, this was the Mesavi study showing that the 7 days to leave. So mind you, if you, as Abhishek already pointed out, if you remove this erroneous data entry, it's very clear that the pulmonary hemorrhage doesn't significantly differ between combined bovine surfactant, or even if you compare within Peractin versus or Cerventa versus Peractin alpha or Pyrosis. That's all.
Okay, so that brings a very important point where Dr. Binesh said that never to take any literature without checking. So very good point to say. So now I'll come to the last part of this analysis, and which is the most important thing, as I believe, is cost effectiveness. So Abhishek, your take on this?
So cost-effective analysis for any intervention is not easy actually. It is not a single intervention. There are many confounders involved in care of a preterm, because cost-effective analysis depends on multiple factors. So there are multiple confounders. There is heterogeneity of interventions delivered. There are unit-to-unit variations. I can say if you have a 26-weeker and a 28-weeker, the cost-effective analysis will differ. And again, added to the fact that if you have an IUGR baby, 30-weeker 800 gram versus a 26-weeker 800 gram, the cost for a 26 800 gram would be definitely different. So if your unit has higher sepsis rates, lesser feeding strategies, or higher BPD rates, cost can go up irrespective of the surfactant used. And if you have a discharge criteria of discharging larger babies instead of discharging smaller babies at 1.5 kg, you can have higher cost. So it also depends on your ventilation strategies, your TPN strategies. What I would say is that cost-effective analysis for this particular intervention is not easy. It's quite complex. Next slide, sir. So with this understanding, if you see, so far what we have understood is that porcine versus bovine, I would agree that dosing at 200 milligram per kg versus 100, you end up having a higher dose, that is cost would become double naturally. But see that you have lesser BPD, thereby lesser length of stay is what I can propose. You have a combined outcome of lesser mortality or BPD, so which again is cost effective. You have lesser air leaks with whatever available evidence you have, thereby lesser cost. And more importantly, if you look overall, there is lesser need for longer ventilation or stay. Thereby, you can have indirect effects on less hospital resource utilization, that is either the human resource or the equipment cost you can save. Next slide, sir. So if you look at the direct evidence from real world data, this is one of the studies from Shaker et al. From level 3, level 4 NICUs of US studying 13,240 neonates. This study actually showed length of stay or the cost was similar between both bovine as well as porcine surfactants. So the cost was also similar. I highlighted this study here because there were another 3 important things which this study highlighted. You can see that mechanical ventilation on day 3 was lesser when you used porcine surfactant. Even mechanical ventilation on day 7 was lesser if you compare Cervanta versus porcine. Again, NICU mortality was lesser if you use porcine surfactant versus cofactant. Overall, if you see, although for the individual patient, the cost would not have made a difference, but for the hospital, the resource utilization was lesser. The human resource utilization was lesser. This is more meaningful for a country like ours, where the mechanical ventilation on day 3, day 7 is lesser, thereby lesser risk of BPD. Next slide, sir. So apart from this large study, we had another 2 studies comparing porcine versus Cervanta and again cofactant versus porcine. So the limitation with this studies were there were smaller numbers, more like a single center experience, and redosing was higher in porcine group, which was unusual when compared to randomized controlled trials. So thereby these 2 studies, smaller studies, quoted higher cost in porcine group. Next slide, sir. So if you look at cost effectiveness in Indian scenario, I think most of us are aware so that in the last 2 years, with the government of India's policy of essential drugs price control regulation or price control policy, so we have ended up with reduced surfactant price. The government of India has made common price for 100 milligram per 100 milligram dose for both porcine and bovine. So this has actually considerably reduced the cost of porcine surfactant by at least 30 to 40%, I would say, with this regulation policy. So after this policy in the last 1 year, we do not have any Indian data available. But if you look at the cost effective of porcine surfactant with less BPD or mortality or less resource utilization, I would say in Indian scenario, we have a clear advantage with porcine surfactant. Cost will no longer be an issue. Next slide, sir. Based on this, I have tried to calculate or I've tried to make some analysis based on this indirect evidence. Let's assume we have a 30-weeker, 1.2 kg baby who is going to stay for 4 weeks. Let's assume that all these 100 babies will require surfactant. So let's assume 100 of these babies are given porcine or 100 of these babies are given neosurf. So the surfactant cost for a 3 ml would be 16,800. 3 ml meaning 2.5 ml per kg for 1.2 kg baby versus for bovine surfactant, that is 6 ml you would require. So the surfactant cost for individual babies would be 16,800 versus 11,342. Look at, let's take a redosing rate of 50%. In bovine surfactant group, you would end up with 5,671 per patient overall. That is, you end up with, I think, close to 56,000 or something, which you divide by 100, it ends up with 5,671. The redosing will be lesser with porcine, adding the number needed to treat analysis, you end up with 2,184. If you look at the air leak, that is 10% in bovine versus 5% in porcine, you end with lower cost with porcine, 100 versus 1,000, less BPD and lesser stay by 10 days. If you add again porcine, there is a clear advantage of 500 rupees per patient. With lesser stay of 10 days, again you have an advantage. Overall, with this indirect evidence, I would say that porcine versus bovine, clearly the numbers are not very different. Cost-wise, lack of data in the current scenario, I would say short-term both are not different, but for the hospital, definitely there will be less resource utilization with porcine. Next slide, sir. I would give it back to Dr. Binesh.
Thank you, Dr. Abhishek. So Dr. Binesh, your argument on the cost effectiveness for the bovine surfactant.
Very interesting scenario that is put forward by assumption prepared by the Abhishek. But mind you, I don't know, it is very center specific maybe, because a 30 weeker staying for 4 weeks and ending up with a NICU cost of 21,000 is almost never happens in, especially in private sector. When we last did our own cost survey, for a typical RDS patient, in a corporate setup, the patient bill comes something around 1 to 1.5 lakh after a four week of NICU stay. So again, that's again very different. And again, the numbers of 30% of BPD reduction, 10%, 10 times 10% of early, these are all valid, provided if you are using alveofact or calfactin. But if you take just Servant or NeoSurf, I don't know how these numbers fit. But again, next slide. Coming to cost is a very curious subject. We often think that expensive products are good, but we again at the back of mind we know that expensive product is not necessarily a superior product. Any of you ever wondered why CuroSurf is costlier than Servanda or NeoSurf? Is the pig lung is costlier to get, or is the research process was complex and costly or time consuming for them to make CuroSurf? Absolutely not. If you read the above article already by Korsted, you can see that they choose pig lung as the source surfactant because that was the one which was available as free for them from slaughterhouse. And all the research and preparation were done by Dr. Korsted and Robertson. And then they tried the product and they found the product to be working, and they did the initial marketing also. Then only they approached the pharmaceutical company, the GC, which is now owning and producing CuroSurf. So the price is a pure marketing strategy. What happened in real life that GC is a small size pharmaceutical company from Italy, and the sales of therapeutic lung surfactant is their primary focus, and that's their primary income. Compared to that, if you take the case of Servanda, the AbbVie or Abbott is a large pharmaceutical company, and they generally use or marketed, at least in the US setting, they utilize Servanda as a doorway to access to the hospital formulary, so that they promote their own infant nutrition product. These are their primary income generating products. This strategy has kept the price of Servanda the lowest. Not the production cost or something like that. The GC's counter strategy to counteract this was the aggressive marketing. They aggressively promote that CuroSurf achieves higher performance when compared to Servanda. And in fact, it was the GC who supported almost all the studies, clinical trials, who directly comparing CuroSurf with other bovine surfactant in order to acquire evidence of product superiority. The studies you have seen in the meta-analysis, like the Spear et al., Ramlan et al., Kogo et al., etc., all has been supported by CuroSurf. Next. And again, next slide. There are previous one. There are many other interesting points regarding how the surfactant market works and why the surfactant cost cannot be increased or decreased or like that. If anybody is more interested, they are welcome to read this article that from published in Biotechnology Advance in 2018. A very interesting read regarding all these points that I said and more about the marketing strategies and the price. Next. But again, as I said, the cost effective analysis is a very different and very complex thing. And without an Indian data, we cannot comment actually, because the Western data or even the old data cannot be extrapolated, because the health economics and resource allocation are drastically different between the countries and even between the years or in the same country. For example, in USA, an average cost for hospitalization of an RDS baby is $55,000. That comes around 40 lakhs Indian rupees. So you can see what's the difference. And the average cost for a dose of surfactant is something around 50,000 Indian rupees. So you cannot simply extrapolate the US or Western cost and effective analysis to our setting and say that one is superior or something. And there are a consensus if you see almost all these cost effective analysis studies, they clearly say that if you see the drug cost only, at least 40% average higher spendage is there with when you use Curosur. In some of the studies, these high drug cost has got diluted over the stay. In some studies, not. And evidently, in the meta-analysis, in the combined effect, there was no difference between the Curosur for Beractin. Next. Again, there were multitude of studies. I'm not going to the final details of this. Some had shown that there was some improvement with the hospital stay, some not. But mind you, on average, if you take the drug cost and treatment cost, Curosur still has a higher cost. And if you use 2 ml, 2.5 ml per kg, in Indian setup, it generally means that the patient has to spend at least 10,000 extra when you when you use a bovine surfactant. Next. So, this is a consensus recommendation put out by none other than Alan Jobe in 2019. Just carefully look at the lines. Says that the animal source surfactant are uniformly effective and stood the test of time. There was some theoretical advance for the 200 mg per kg dose for Peractant alpha or Curosur, but however, the animal lung source surfactant are effective at even at lower doses. So in low resource care environment where cost is paramount, the surfactant dose and choice may differ without compromise of efficacy. So basically what it means that if you are in a setup where a 10,000 extra spending on a drug is not matter for either the hospital or for the patient, fine, go ahead and use Curosur with 200 mg per kg per dose. In other settings, please don't use Curosur. You go with bovine surfactant, which will be more cost effective as of that what I have to say. Next, I guess if that's something.
Okay, thank you to both of you. So now I've been asked to summarize. So before summarize, I'll give you all chance for your conclusion statement. But let me just say that this is not a very easy topic. That if you, because here we can't say our practice. Here we are to look at the evidence. So I may believe Curosur is better, but I use Survanta. That doesn't make sense. So as of now, the evidence in each of these clinical points, be it BPD, ear leak, pulmonary hemorrhage, redosing, cost effectiveness, are not extremely clear and directly towards one side. Otherwise, there is no justification of doing this debate at all. So I would still leave it open to all the attendants to hear to this evidence and then make a choice. As Dr. Binay said, and as it looks as of now, but be careful that these are Western data we are interpreting, not Indian data. We don't have strong Indian studies. Our babies are different with a lot various parameters. So you may choose one over the other, but you must know why you are choosing that. Okay. So just before moving ahead, I'll take one of the questions we are having in the question box. Incidence of sepsis in neonates receiving surfactant and does surfactant increase the risk of sepsis? I really don't think so, but maybe some of you can take that question.
Yeah, Vikram, if I may,
Yeah.
the concern of surfactant increasing the risk of sepsis is purely secondary to your intervention.
Yeah.
So if you are giving the surfactant giving, especially if you are using Ensure, is an invasive process. Even Lisa is an invasive process. So if you are, unless otherwise stringent in your assessing practices, there is obviously a risk of sepsis. But even otherwise, there is some evidence to say that in a diseased lung, the surfactant contained proteins like DPPC, and many of these proteins has anti-infective properties. So at least there are some theoretical evidence or experimental evidence to say that if you use the product which is higher in DPPC, especially DPPC, there's a chance that your infection risk on the lung may goes down, but no clinical evidence to say that one or one. So mainly the sepsis is secondary to your procedure rather than the surfactant use. That's what I feel.
Okay, so another question in the chat box says, any change in the trend of preferring a surfactant in the last 10 years? So,
yeah, I am not sure about the Indian data, but in US there's a clear-cut trend. The same article that is suggested you shows that there's a clear-cut trend of more and more people using Curosur but the reasons are not that straightforward. There's a very complex thing, but there's a clear-cut trend that, especially in the US, more and more people preferring Curosur.
okay, so let me just put it this way. So suppose you are using Servanta, suppose. So what data would you want to shift to porcine, given the fact that the meta-analysis does show a benefit? What additional data would you want?
No, I didn't get it. I didn't get the question.
So suppose as of now, one of the meta-analysis is favoring porcine. And suppose you are using bovine in your setup. So would you directly take this meta-analysis on prima facie, which has certain lacunae as you pointed?
I completely disregard the pattern meta-analysis for the obvious reasons that I already
Okay.
and
So
I am only interested in Servanda versus Curosur, and the meta-analysis shows no difference between.
Okay, so would you want a good Indian trial of these two surfactants, and that would maybe convince the people?
Obviously.
Yeah. Okay. Sure. So now I'll give Dr. Abhishek the chance for the conclusion for the porcine part. Dr. Abhishek.
See, I would agree completely with you, Vikram sir, regarding the recommendations. We are not recommending porcine is better than bovine. With available evidence, I think porcine has an upper hand compared to bovine with obvious limitations, whatever Dr. Binesh sir mentioned. So there are limitations for this meta-analysis, but this is the best available evidence we have. But the evidence is towards porcine, as well as most of the recommendations from major groups like European Consensus or Canadian is towards porcine at 200 milligram per kg. I agree there are several challenges for the Indian scenario with respect to cost especially, but with the current regulation of price control from Government of India, the differences may not be 10,000, but the difference may work out to be around 4 to 5,000, I would say. So with the available evidence, I would conclude saying that porcine, if you're using a 200 milligram per kg, if cost is not a concern, compared to bovine, has a lower risk of BPD or mortality, as well as air leaks and redosing. So pulmonary hemorrhage, I would find there's no difference with regulation of price control and proven benefits on reducing BPD. So I would say porcine has a clear advantage with available evidence. And with, as Dr. Binesh and Dr. Bikram mentioned, I would wait for Indian scenario as well before making it as a recommendation. Thank you.
Dr. Binesh, your argument?
Yes, please. Okay. Again, I would agree with Abhishek in the way that if you compare porcine with the bovine as a group, obviously the porcine seems to have some advantages. But if you're using a product like in India, like Servanda or maybe even Neosurf, as I already showed the evidence, say that nothing to say that definite evidence to say that Curosur is better than Servanda as single product if you compare head to head. But obviously, there are some trends towards favoring Curosur if you use it at 200 mg per kg per dose. Cost effectiveness, very doubtful. So my take is that if you are working in a setup where the cost is not that of a concern and the patient spending power is good, fine, go ahead and use with Curosur 200 mg per kg per dose. But never use, but I don't agree with the practice of using Curosur at 100 mg per kg per dose, which definitely has got no advantages over Servanda, just only the adverse effect is increasing the cost. Next. Again, the same thing has been recommended by all the European consensus. All the head-to-head trials say the surfactant has similar efficacy. So you choose depending upon your interpretation of evidence. Next. And this, we discussed only the pulmonary evidence, pulmonary outcomes. If you see the long-term outcomes and extrapulmonary outcome, even the Trident and meta-analysis, they have done another meta-analysis on extrapulmonary outcome of surfactant. All the studies show that there's no difference, absolutely no difference between bovine or porcine or even between bovine, if you take the long-term outcome or extrapulmonary outcome. Next. So I will stop with a philosophical question. Do we really want porcine to be definitely better than bovine? Probably no, because we just don't have that much pig to sacrifice. The demand for the surfactant in world is too huge to be filled with a single source of bovine or porcine. So unless there is a better synthetic surfactant comes up, I guess this is the good scenario for a point of inequality or point of equality may be a better scenario for all of us. That's
Okay,
it.
so I'll just conclude with the summary of the discussions today. So porcine surfactant at a dose of 200 milligram per kg possibly demonstrates clinical benefits above bovine surfactant at a dose of 100 milligram per kg. Cost-effective analysis is unavailable from developing countries. Observational practice data indicates most units use bovine surfactant. As stated earlier, it will be unethical to test lower doses of porcine surfactant in the current scenario. And given the large volume of bovine surfactant, it will be not feasible to test higher doses of bovine surfactant due to the volume issues which may cause lung edema. So with that, I would thank both panelists, and let's see a few comments we can see in the chat box. So Dr. Bhaswati has told that most of the government setups in West Bengal have free supply of Curosurf. I'm not aware of that. So if that is the thing, then that data analysis would be interesting to see with a retrospective equivalent time data analysis. But again, that would have several confounding factors, most importantly early CPAC. But that would be interesting to see. So anything else in the chat box I cannot see, which we have not answered. In the question box, I can see any comparison for non-RDS conditions. I think that's a very different topic, which won't be justified to answer in such a small time. So maybe we can answer that sometime later. But yes, in certain conditions of meconium aspiration, there is a use for that. So are there any more questions from the participants? I think one chat box has come up. Yeah, Dr. Shami, please.
Yeah. First and foremost, a huge thanks to Dr. Bikramjeet and both the panelists today. We are indeed extremely lucky to have the expertise of Dr. Abhishek and Dr. Binesh Balachandran. They have been very scientific in their presentations. They have dissected data very scientifically and have tried to give us some kind of a conclusion. And as Dr. Bikramjeet said, and I think so as both the panelists have said, it's difficult to come to a straight conclusion because there's been a change in the trends of therapy. As you must have noticed during the course of the discussions, the indications for surfactant use, especially in the prophylactic segment, have literally away with other than less than 26 weekers. When we were students, if I am not mistaken, prophylactic use was even advocated for less than 30 weekers, but now you've almost done away with that and you've come into the less than 26 weekers. The kind of therapy which is needed as far as post-surfactant administration is concerned, that has also changed. And I think so when you are trying to collect a large number of cases, you are inevitably looking at 20 years data, but like what Dr. Binesh has very correctly pointed out is that in trying to take large number of data, we have overlooked the fact that in the last 10 years, there has been a huge change in the strategies for surfactant therapy. So it would be fair to conclude today by saying that though there is an overwhelming evidence for the porcine use, I think so we constantly need to audit ourselves as we are going along, because I'm sure there are settings where the bovine surfactant is available. There would be institutions which would be using the bovine surfactant in the dose that has been prescribed. Once we take care of the ethical issues and once we can, contribute a lot to the data, there are a lot of very young neonatologists over here. My appeal to you would be, please contribute data from your respective units. And I think so that will help us in getting a more definitive answer. But we will conclude today by saying that porcine is probably the one which is working better at present evidence. But then if you have the bovine, you will not be putting the patient at any great disadvantage. And maybe there might come a time when the equivalence of the two will probably be established. But again, for that, we would need more data. Thank you once again. We would love to hear from you once in the future. And this has been a really, really stimulating discussion. We've had nearly 90 participants in today's, debate. And it is an evidence and a testimony to the fact that we had a very, very scientific and logical discussion. Thank you very much on behalf of the New Kolkata Academy of Pediatricians. And here's wishing all the attendants a very, very big thank you. And also stay safe and stay well. Good night to everyone. Thank you.
Good night.